Good afternoon. It gives me great pleasure in introducing our next speaker, Professor Roopen Arya. Professor Arya is the director of the King's Thrombosis Centre and Professor of Thrombosis and Hemostasis at King's College Hospital. He trained at Oxford, and he is the clinical lead for VTE and director of National VTE Exemplar Centres Network in England. Please welcome Mr. Arya.
Thank you.
Let me assist you.
It's a new stick.
Okay, but you figure it out already. Where it works. Don't.
Okay, we're good to go. Assalamu alaikum, and thank you once more for inviting me to speak at this meeting. And this is the second part of my talk. Yesterday, I spoke about implementing system-wide VTE prevention, and I filled you in about details about the program in England, where we've developed a comprehensive and systematic approach to VTE prevention. And really, it's the first national initiative of its kind anywhere in the world, and it's been held up as such by the ISTH, who've recommended that it be used as a kind of template for other healthcare systems. We've recognized that VTE prevention is a key patient safety initiative, delivering high-quality care and reducing avoidable harm, making our patients safer in the hospitals. And we've been fortunate enough to benefit from many system levers within the NHS that have driven this quality improvement process, which I described yesterday with a multi-pronged approach, a multidisciplinary approach with not only the doctors, but nurses and pharmacists playing absolutely essential roles. Each ward has a named link nurse who leads on VTE prevention on that ward, and the pharmacist also have a duty in ensuring that appropriate prophylaxis is administered, and VTE risk assessment is a key performance indicator on the wards. So really, we've come to a point in the 6th year of the National VTE Prevention Program when VTE prevention is considered business as usual. All the system requirements are in the NHS acute care contract, whether it's risk assessment, whether it's appropriate prophylaxis, the need to audit VTE prevention on the wards, and also perform root cause analysis on all cases of hospital-associated thrombosis. And the National VTE Exemplar Centres Network, which I lead, will provide leadership and disseminate best practice. But I think a very important step going forward is to have a better understanding of the outcomes in VTE prevention. So this is the VTE prevention pathway. To be successful in preventing hospital-associated thrombosis, first and foremost, you need to identify the at-risk patient, counsel them if they're at risk, and prescribe appropriate prophylaxis. An estimated 60 to 70% of most of the adult hospital population would be considered at increased risk of venous thromboembolism. So how do we judge the impact of all the VTE prevention efforts on outcomes in patients? One way of going about it is to look at the measures of process, be it the risk assessment rates or the prophylaxis rates, and the other would be to look at real-world outcomes in terms of hospital-associated thrombosis as well as bleeding. So the cases of hospital-associated thrombosis are identified by root cause analysis programs. At a national level, we have coding for cases of venous thromboembolism as well as for the mortality due to VTE through the Office of National Statistics. However, we have to recognize, while understanding VTE outcomes, that prophylaxis is only going to reduce 50 to 60% of cases of venous thromboembolism. There are limitations of the prophylaxis that we use. Also, when going to identify cases of VTE at a national level, the limitations of ICD-9 and ICD-10 coding are very well described, particularly by Richard White in the US. The limitations of death reporting, since we've invested a lot of effort into education and awareness, the house officers, when they're filling in the death certificates, are much more likely to think about VTE as their number one cause of death. So we are victims of our own success. And there are fewer and fewer autopsies being undertaken in our healthcare system. And I think most importantly, there's an increasing realization of the limitations of the outcome indicator as a marker for the quality of the process. There have been 3 recent papers in JAMA, for example, that have very clearly described an ascertainment bias. So you are more likely to find VTE the more interested you are in quality of care, and it depends also on how hard you look. So ironically, in the first of these papers, the hospitals that were the best at VTE prevention also had the most cases. So we've unfortunately created a rod for our own back. So I think if we look at markers of process, there's been a 25% increase in admissions to the NHS in the past 5 years. Each month we have 1 million admissions to the NHS. And all the hospitals have to submit to a central kind of business unit their monthly risk assessment figures. So it's a big, big ask. And we went from doing, very few systematic risk assessments to demanding overnight in 2010 summer a kind of 90% risk assessment target. And currently over 95% of all adult patients in the NHS are risk assessed for venous thromboembolism, which is, I think, a huge, huge achievement on the part of the NHS. Capturing the appropriate prophylaxis rates at a national level are very difficult. I mean, we can go and audit the patients on 1 or 2 wards, but how do you do it at a national level? So we looked at the usage of the prophylactic dose low liquid heparin, and during the past decade, there's been a 27% increase in the use of prophylactic low liquid heparin. In 2007, the NICE guidance for VTE prevention in surgical patients was published. And in 2010, we saw the launch of the National VTE Prevention Program. So we know patients are being risk assessed. We know we are using more prophylaxis. And again, we were not starting from zero. If you look at 5-6 years ago, if you look at the endorsed data, 70% of the surgical patients were getting prophylaxis and 40-50% of the medical patients. So you are expecting an uplift of maybe 20-30% at best. So one approach is by auditing VTE prevention on the wards. This is we have an electronic audit tool in my hospital, and every 3 to 6 months, the junior doctors and nurses get together to audit 500 patients across all the wards. So this is effective at a local level, and it leaves me, for example, with a good knowledge of the very high appropriate prophylaxis rates across our wards. At a national level, this is more difficult to do, because if you look at our trust quality boards, the national audits take superiority over any other quality indicator, because it's easy to identify, for example, the number of cases of myocardial infarction or the number of cases of stroke. But how do you audit a process that is applied to every hospitalized adult inpatient? Therein lies the challenge. And it's something that we are addressing at the moment in a feasibility study along with the Healthcare Quality Improvement Partnership. The other way about it is trying to identify the cases of hospital-associated thrombosis. This is data in one of our regions of the NHS using HES, or the Hospital Episode Statistics, based on coding, which gives us approximately 5 to 6 cases of VTE per 1,000 admissions. The other way, there are some people, particularly some surgical groups, who believe the only meaningful outcome is mortality. Other softer souls, particularly physicians, believe in even asymptomatic VTE is worth looking at as an outcome, then symptomatic VTE, and ultimately death. So our national data indicated that since the National VTE Prevention Program started, we've seen in the first year a 9% reduction in the projected national VTE mortality. And then there was also a study from the Koru group in Birmingham, Professor Domenico Pagano and his colleagues, who linked this improvement to achievement of the 90% risk assessment target. So we can see that the total VTE-related deaths reduced by 8%, and the total primary VTE, that's where VTE was the number one line on the death certificate, went down by 15% in hospitals that achieved the 90% risk assessment target. So really, these are all good things, and for the first time anywhere globally, we've got national data around VTE outcomes, and we decided in our wisdom or otherwise to produce a national NHS outcome framework indicator. And again, this was problematic because with in-hospital VTE, it's very difficult to differentiate between those admitted with VTE and those who develop it as a consequence of hospitalization. Therefore, we decided to use as an indicator the death from VTE-related events within 3 months of discharge from the hospital. So you can see that from 2010 to 2011, there was that reduction in mortality, but the next year, much to my disappointment, the figures went up. And I think there's many reasons for this. One is the ascertainment bias. The other is also that in 2011, the government introduced something called payment by results, when all hospitals had to code their cases of VTE. So suddenly the number of cases went up. And last but not least, we have a much older and sicker inpatient population than previously. But I'm pleased that in subsequent years now the figures are beginning to level off once again. So this is our framework indicator. We also have local data. This is from my group at King's, where we have shown that introducing a comprehensive VTE prevention reduces the cases of hospital-associated thrombosis by 12%. Again, this was a real wake-up call for us because we have 1,000 beds, and yes, you see deaths from VTE, you see cases, but to start to identify those cases gives you an idea of the true burden of disease. So when we started doing this, to our surprise, we found 20 cases a month of hospital-associated thrombosis and 1 or 2 deaths each month, which was very worrying. So the most robust way of identifying these patients are through positive DVT and pulmonary embolism scans. This enables us to identify the true burden of disease, to identify what goes wrong and what to do about it. And then the data gets reflected back to the consultants and the teams in charge of the patient. So this was our root cause analysis program, which, as I said, showed a reduction of 12% in the first year. And also, we were able to identify the specialties that contributed most of these patients, which unsurprisingly are acute medicine and the high-risk surgical specialties, which are neurosurgery and orthopedics. But again, when we look at our local data over the years, the trend has flattened in that, the number of cases of hospital-associated thrombosis now is constant. The inappropriate prophylaxis rates have gone down from 40% to 8%, and the majority of cases that we see are due to failure of gold standard prophylaxis. And so underlying the root cause, understanding it is very important. So we have begun to analyze at a national level, these cases in whom the gold standard thromboprophylaxis has failed, and what the kind of risk factor profiles are in these cases, whether it be, the age, reduced mobility, dehydration, medical comorbidities, which will enable us to improve the holistic care of these patients and advance beyond the limitations of the current prophylaxis regimens, because should we be thinking of giving extended prophylaxis to certain patient groups, particularly the cancer patients who are having major abdominal or pelvic surgery, multimodality prophylaxis, early mobilization, better hydration. And there's a very substantial rump of conditions with possible healthcare-related VTE in which our understanding of the risk is poor, including lower limb immobilization, mental health care, and nursing homes, because we know these elderly patients, when they're discharged from hospital, are in a pretty similar state often to what they were in when they were admitted to hospital. So just in the next few minutes, I'll just cover some of these gray areas of evidence and see where we are headed. Thromboprophylaxis and lower limb immobilization remains a controversial subject. We still all continue to see deaths in people with kind of plaster casts. There is an increased risk of VTE, but the absolute risk is low. There was a Cochrane review that concluded that outpatient prophylaxis reduces VTE, but this was 1,500 patients within 3 of these studies using venographic endpoints. 80% were distal DVT. So it was a very heterogeneous population, and I think this is a weak recommendation. My colleague Bill Geertz in Toronto did a study, the CAF study, which showed symptomatic VTE was only 0.6%, and half of these were distal DVT. They did a study then called the DCAF, which was dolteprane versus placebo, and the interim analysis showed no significant difference, so this was stopped early. The study by Zheng and his colleagues again showed that low molecular weight heparin didn't work. Many of you are probably aware of the 2 studies in the New England Journal just 2 weeks ago. The podcast study in lower limb arthroscopy and the podcast with a C in lower limb immobilization, which again showed that prophylaxis did not work in these patients. But the podcast study, to my mind, is a bit of a strange study because they excluded all the patients whom I would ordinarily consider at high risk, which are those with previous VTE, the cancer patients, the pregnant patients. So they were all excluded, and they gave them not the regular prophylactic dose, but they gave them 2,500 units of dolteprane. So I'm afraid that's an opportunity missed. It's a negative study, but negative, you've given low-risk prophylaxis dose to low-risk patients. So I don't know quite what they were thinking when designing this study. But nonetheless, we all continue to see cases, we continue to see deaths in these patients, and we need to have a certain baseline of risk recognition. NICE give a rather weak recommendation that consider offering prophylaxis. And to my mind, your local guidance should pick up the highest risk groups, which are previous VTE, cancer, and pregnancy. And those groups would be eligible for prophylaxis while they're mobilized. VTE in the mental health setting is another area in which hospital-associated thrombosis is frequently reported, and there are many hospitals in the UK that have decided to adopt the National Risk Assessment tool and give these patients prophylaxis. But the evidence for the increased risk of VTE is weak. There are observational studies that show that it might be a problem. Similarly, there are MHRA reports of risk with clozapine, olanzapine, aripiprazole particularly, but there are no risk assessment models. We don't know how many of these inpatients are at risk. We don't know what prophylaxis we should give them, and we have no guidance to help us. So I think it is premature to consider giving them prophylaxis. Nursing homes, likewise, is an area in which we are all aware that patients die of venous thromboembolism. There is some epidemiology to support it. There's also evidence suggesting that it's not taken seriously enough in the nursing homes. There's not much data about risk assessment. This John Hyde study published 2 years ago accrued 90 patients over a 7-year period. So it's not a strong study. There's no randomized controlled trials, and the ACCP guidance suggests against the routine use of prophylaxis at the moment. So in summary, I hope I've demonstrated to you in the course of my 2 talks that we have been successful in developing a comprehensive systems-based approach, and that there have been demonstrable improvements in both process measures and VT outcomes. But I think the major challenge lies ahead in that, despite everything we are doing, a substantial burden of healthcare-associated thrombosis remains, and sustaining and improving best practice in VT prevention is a continuing challenge for us all. So I'll stop at that point, and thank you for your attention.